So I'd like to start grand rounds today, and let me do so by first welcoming in the audience some individuals who are going to be interviewing tomorrow for residency positions at the University of Washington. Welcome. This is the beginning of our interview season, and you have the distinct or the dubious distinction of being our first group of candidates. So we really are looking forward to meeting you tomorrow. Our speaker for the first hour is Heidi Blume. Heidi, I discovered, I didn't know this about you, Heidi, that you were born in Canada, but you're a United States citizen. Heidi got her undergraduate training at Hopkins and then her MD degree from Harvard. She came to the University of Washington, where she did all of her training in pediatrics, pediatric neurology, and of course took a year of adult neurology as part of that experience. Heidi then did something which is a very unique and special experience in clinical research training, and that is she got one of the coveted positions in the Robert Wood Johnson Clinical Scholars Program. At the time, the University of Washington enjoyed having that program here. As I say, it's a very, very competitive program, and Heidi was one of the chosen few. As part of that training, and I think we may see evidence of her training on display today, she also did a Master of Public Health, which I'm sure included a lot of training, Heidi, if I'm not mistaken, in statistics and clinical trial design, etc. Heidi's interests are broad. Her published record indicates that she's had interest in things that really span from the bench to the bedside, and I think more now focused on the bedside. And her interest has begun to turn most specifically in the direction of childhood headache syndromes. And today Heidi is going to talk about headache following TBI, traumatic brain injury, and concussion in pediatrics. Heidi, we're looking forward to your lecture. Those of you in the audience for the first time may not realize that we stream this lecture to other sites, and we're also having an experience with the Occupy Wall Street chapter in Seattle. They're threatening to occupy some of our roadways, so that may have kept the hordes from coming today. So Heidi, please.
Thank you very much, Bruce.
Do you know the...
It's right
here.
There.
You can put that on.
Thanks. Yep. Thanks. All right. So thanks for that very kind introduction. I think the RWJ program was a great experience, and I certainly learned enough to know at least what I didn't know. So, all right. That's not... And I do really appreciate everybody showing up who's here because the Occupy Seattle movement is threatening to take over Montlake Bridge, and which is like right next door, or the University Bridge, I hear, is their new plan, and that's about 3 blocks away instead of 2 blocks away. So
you might as well cancel your other interviews if you're staying here.
Right. So hopefully that in the rain is also maybe a factor in how bad the traffic will be. But the other thing is I'm not sure if anybody would have noticed if they took over Montlake Bridge because the traffic is horrendous anyway. So today I'm going to talk about headache, looking after TBI in kids and adolescents. And first, what is post-traumatic headache? When does it happen? Then epidemiology of post-traumatic headaches in the adult population, because we've got some data there, and a little bit of what we've been doing in looking at the pediatric population, looking at particularly some of the studies that have been being done here. Then a tiny bit, just a little bit, on concussion in youth. I'm sure that you all have heard from Stan Herring and Rich Ellenbogen when they were here, but just to review that a little bit, because that's a big issue in the news, and if you don't see these kids in your clinic or in the ER, you may be your nephew, niece, grandson, granddaughter, whoever may be having issues either with them or their friends. And I just review a couple of pretty classic cases that we're seeing in clinic, and talk about then recommendations that we have now for the evaluation and management of these types of problems. So what is post-traumatic headache? The ICDH, the International classification of headache disorders has defined it as a headache that develops within 7 days of the head trauma or regaining consciousness in the case of moderate or severe TBI. And the criteria, there's mild and moderate and chronic and acute. So these criteria are really mainly based on how bad the injury is, how long the headache is lasting. But I think people who look at this are finding that there's some deficiencies in these definitions, and that doesn't say anything about headache characterization. Is it migrainous, non-migrainous? It's more like tension headache. And there's also this issue about the 7-day rule, because particularly in moderate and severe injury, it seems like some people definitely have headaches that are associated with their injury, but don't really show up until later. So what do we know about post-traumatic headache? So we know it's one of the most common complaints following a traumatic brain injury. More than 90% of adults, report headache after a mild TBI or concussion. And there's some military data from the 90s, sort of before the whole the Iraq issues, and that mild headaches may be more common after mild TBI in the military than after the moderate or severe TBI. And again, there's some reasonable data that women have a higher risk of chronic headaches following traumatic brain injury than men. And it's not a small issue in that up to 50% of people are reporting headaches a year after their injury. So Sylvia Lucas and Kathy Bell and Jeannie Hoffman and colleagues looked at this at the U in a population of folks with moderate or severe brain injury who are seen at Harborview. And found that so they really did, it was a prospective study looking at baseline reports of headaches, then what they were experiencing at the time, and then followed them for 12 months out. And they found that about 20% had headaches before the injury, which is not surprising, but the fact is it's in the upper 46%, 48, 46, 44, 46% had headaches all the way out to 12 months. So this is in contrast to a lot of the prior studies that had shown that more like 20% of folks were having chronic headaches long after their injury. So it looks like it may be more of a problem than we had thought. And again, they also found, no pointer, but I'm supposed to use this pointer, there we go. More women had new headaches after injury than men. And about 50% of these post-traumatic headaches really had migraine characteristics, and it could be classified as migraine. So why should we care about this in kids? Like kids don't get headaches, right? That's not a problem. Nobody has problems with headaches. That's what I think a lot of the general population thinks. They're surprised when their kids who are 10, 12 have headaches, but it's actually a pretty common problem. And somebody at the CNS meeting said, well, sure, I'd love to take care of something that gets better on its own, when we were presenting some of our data on post-traumatic headaches. But this is not a small issue, and this is data from several years ago about looking at kids from 5 to 14, and there's 500,000 kids are hospitalized or evaluated in a hospital setting for traumatic brain injury every year. So that doesn't count the older kids or the older teenagers. And we know that there's many, many, many kids who never get evaluated in the hospital when they have a concussion. They may see their doctor or may not see anybody. So there's probably estimates of more than 1 million kids in the U.S. with concussion every year. So what do we know? Looking at mild TBI and concussion, we know that high school athletes in general take longer to recover from concussion than college athletes. This is looking at neuropsych testing and other kind of more general post-concussive symptoms, not just at headaches. Few studies have looked really just at headache or looked specifically at headache. About a month after mild TBI, up to 60% are reporting headaches. And at 3 months, this is another good prospective study looking at kids who are seen in the ER with mild TBI, and 14% of school-aged children remain symptomatic 3 months after their supposedly mild TBI. And at a year, over 2% were still symptomatic, and 1.3% of these had post-traumatic headaches. And that 1% is including kids from age 1 month to 18 years. And so probably if you look at school-age kids who are going to be at higher risk for having headaches, it may be more like 2%, but I can't tell from the way that the numbers are published in that study. And the whole issue of gender and sex comes up because, as we know, we've heard from Dr. Murnova and Sylvia Lucas earlier, that headaches and migraine are much more common in women, much more common after puberty. And it appears that girls are at higher risk for concussion. In the same sports, there's a higher prevalence or incidence of concussion in girls and in boys. But trying to tease out how the kids recover from concussion isn't quite clear yet, but I think a lot of people think that the girls, in general, when you see kids clinically in clinical practice, that the girls seem more likely to have problems after concussion than boys. So what happens after moderate severe TBI for headaches in kids? We really don't have much data. There's not anything that I could find that's been published that really reports on headache. So this offered an opportunity for me to work with Fred Rivara and the Harborview Injury Prevention and Research Center. They have a great study, Child Health After Injury, or CHI study, where they looked prospectively at kids who were seen in the ER or hospitalized with mild or moderate or severe traumatic brain injury, and compared the controls with arm injury, recruiting from a bunch of hospitals in this area, as well as CHOP in Philadelphia. For this study, looking at headache, we just looked at kids who were 5 to 17. We had over 400 kids with mild TBI, 71 kids with moderate or severe TBI, and then 137 controls with arm injury who did not have head injury. And they followed them prospectively. The 3-year data is just about to come out soon, but we've got data from the baseline 3 and 12-month follow-ups. So we have there were just a few questions asked about headache. There are 2 surveys. One was to the parents, one was for the teenagers. The younger kids didn't answer their own questions. So we do not have baseline data, unfortunately. So this is just looking at controls versus kids with TBI. So TBI is more common headache is more common after mild TBI than after arm injury. It's not significantly higher after moderate to severe TBI, interestingly. And the teenagers, again, seem to have a little bit higher risk of headache. After we stratified this looking at age and gender, because in headache syndromes, age and gender are very important factors. And the older kids, the teenagers, did have a higher risk of headache after mild TBI compared to controls. But the younger kids almost was significant, but not quite. So 40% versus 20%, but still the confidence interval crossed 1 there. And again, we found here males had really not much difference in the incidence of headache at 3 months, a little higher, but it was certainly not significant. But whereas females had a significantly increased risk, or increased prevalence, of headache after mild TBI when you look at them compared to the arm injury group. And interestingly, we found sort of the inverse, expected relationship here with the younger kids. With moderate or severe TBI were the ones who really were complaining, or their parents were reporting headaches after 3 months after. So this would qualify as a chronic headache at this point. And then we just briefly looked.
Do you want to define mild TBI versus moderate TBI?
So mild TBI is an alteration of consciousness. They come with a Glasgow Coma scale of, I think, 14 initially, and by 15 either at discharge or 24 hours after injury. It's defined by the CDC criteria. The moderate severe, the kids who fit that criteria clinically, who had a skull fracture, were still included in the mild TBI group in this study. That's one of the problems when trying to figure out TBI issues, is that the different definitions vary between studies. You could also have a small bleed on CT that didn't disqualify you from being in the mild group in this group. The moderate and severe were grouped together because they were the groups would be too small otherwise, and they were more similar. Though I have other tables. Almost all of those kids were hospitalized, and the severe. It was based on motor GCS scales in terms of. So those were kids who were had abnormal GCS scales 24 hours into it for the 24 hours.
But a bump on the head without any alteration of consciousness
was not, no. So you need to have some sort of alteration of neurological status. I have a definition of concussion in a few minutes. But the official definition of mild TBI was a little long for these slides. I have that later. So here that was any headache, and we also looked at more severe headaches, so more than 5 out of 10 headaches. And again, here the only things that were significant when you look this way were that the females had a higher incidence of headache, and again, interestingly, the young kids also had a higher incidence of headache after moderate or severe TBI, but not after mild TBI, which was interesting, and I'm not sure. We're not sure why this was. If it was that it could be that the parents are more worried about them, or if there's really something different in the physiology of the younger kids that puts them at higher risk for problems after moderate or severe TBI, which is sort of different from the adult or teenage pattern that we're seeing in the other older kids. So I also looked at just the teen report. This is the teen, because they were asked different questions. And again here, that nothing reached significance, but there's some trends that were interesting, particularly in that the females looked like they had, it was more likely that they're going to have headaches, even though it wasn't significant. Because the numbers, for better or for worse, males get more TBI than females, so the groups, there were not as many females in these TBI groups as males, so they were smaller groups. But you look at the percentages, 7% versus 31% were bothered a lot by headache. 30% versus 50% had a higher score on the FACES scale, and 23% versus 55% had a headache worse than 5 out of 10 in the last week. So again, the approaches significance, particularly with this last one, but not quite. Sorry. Is there a mouse? No mouse. Okay, just this thing. Okay. So, anyway. So, interesting. Then we also looked at 12 months. And here, not surprisingly, didn't find any difference in any headache at 12 months. Again, we wonder if the females will have a higher risk at 12 months after mild TBI, but not after moderate TBI in this analysis. And same thing for the 5 out of the more severe headaches. No significant difference, but the numbers make you wonder a little bit about the female group. And here, again, the teen report, same thing. Nothing is quite significant. We got crossing the 1 in our confidence interval, but relative risk of 4, 6, and 3 with the different questions, and the percentages are compelling, if not significant. So I think this is something to look at more in future other studies, and hopefully we'll be able to look at it a little bit differently when we get some of the results back from the 3-year study. And again, here, even this came out in a teen study, which wasn't notable in the big group, but from the teen survey, even at 12 months, moderate severe groups, looks like there may be some issues there even at 12 months, which we didn't see in the mild in the parent surveys. This is the other interesting thing, just looking at trends of headache incidence and age, or prevalence, sorry. That you see this increased percentages of girls with headache after mild TBI. You really don't. Sorry, this is not great. You don't hear. So the incidence is higher in teenage girls than in the younger girls, and more significantly different in the teenage girls compared to the arm injury girls here. And with the boys, it's really no significant difference at any age group. It's hard to define a trend in incidence of headaches with the boys. And that's this. Mm-hmm.
Sorry, I think you went over this. I'm trying to remember. What's 5 out of 10 headache?
Oh, so 5 out of 10 headaches. So there's a headache scale. So like 0 is no pain and 10 is the worst pain ever. Sort of is one way you can describe it. There's also a FACES scale that kind of goes along with it. So.
One of those headaches?
No, so 5 out of 10 means they've had a 5 out of 10 headache in the last week. Sorry. So in general, we found that headaches are more common after mild TBI than after arm injury, which had been sort of controversial, actually. This seems to be particularly a problem for girls and teenagers after mild TBI, and maybe a problem for younger kids after moderate or severe TBI. And that a year after injury, most kids seem to go back to their baseline prevalence of headache, but I'm suspicious that those teenage girls are actually at risk for having headaches even after mild TBI 12 months after the injury, and perhaps even after moderate or severe TBI. And the risk factors for headache after TBI include, from this study, we can conclude they look like female sex and age and severity of TBI are things that are going to be important to consider. In the 3-year study, we're going to be able to look at family history of migraine and report of migraine before injury, but we didn't have that data for this study.
Do you have any grading for
No. No, most of them were. The 99% of them went home, and all of them, like 98.6, had GCS scales that were normal. So, and I think there may have been one or two that had surgery to correct the fracture. But most of them were relatively minor arm injuries.
Because major injuries would require non-medications.
Right. That's true. And they do have they have a lot of that data and quality of life data and other kinds of things that we weren't able to look at in this study.
Heidi,
Mhm.
a arm injury is stressful. Was there the capacity to compare the arm injured youngsters versus a control population for the frequency of headache?
Not in this study. That's the one. This study was designed to look at health after injury. It was not designed to look at headache. So their goal was to try and take the stress of injury out of the picture. I mean, so that both groups would have had some stress of injury. And there's always a question of if kids who come to the ER with a mild TBI are more prone to having headaches in the first place. Maybe kids with headaches are more likely to get a concussion, and then you see the results that they look like they have more headaches after mild TBI. But no, we do not have a uninjured control population. I believe they had some recommendation about traumatic brain injury research that recommends using an injured control rather than an uninjured control. But it would have been interesting to see an uninjured population as well to see where they were going, because the study was designed to look at health and function after TBI. Mm-hmm.
Anybody make a point of collecting data about the intensity of analgesic use in these people? Because you can create headaches, and maybe that's what happened in some of the arm injured people with intense analgesic use.
Yeah, it's possible. There is data about medication use in the hospital. I don't think we have the data about it use and as much data about it in outpatient setting. But actually, the rates of headache in the arm injury group are comparable to, or even a little bit lower than kind of reported control populations. So I don't think that's going to be a huge issue. In fact, sort of there's fewer teenage girls with headache in the arm injury group than I would expect. So that's, again, one of the things that kids who are prone to having headaches, or there's something different about them, and that's why they get their brain injury in the first place.
So how do you explain mild cases and less headache in these moderate?
No, they have more headache usually. I mean, but so for the young kids,
So how do you explain?
how do I explain that?
Yeah, just the discrepancy between mild and moderate.
Because I think there's some pretty good evidence that the mechanics and what's going on between the mild TBI and moderate severe TBI are quite different. Moderate severe TBI, there's often blood. There may be other kinds of things going on. Mild TBI is more of a functional change rather than a structural change, whereas in moderate or severe you often have structural changes as well. And we don't know why, but there's in the adult world, again, it's been pretty well established, or at least it had been until Sylvia's study, that studies have found higher rates of headache after mild TBI than after moderate severe. People have wondered, is it because the adults with moderate or severe TBI are too impaired to complain of headache? And it's a good question. We don't know the answer. Oh, so this brings up. All right, the back button. It's not working. There we go. So this also. The epidemiology of these headaches that we were looking at in kids seems to follow along with the epidemiology of migraine, more common in women, more common in teens and younger kids. And is there some common pathophysiology between the two disorders? And the fact that in the adult studies they're finding that a majority of those folks who have post-traumatic headaches can be classified as migraine-type headaches. That's still theory, and there's not any basic science data to go along with that at this point that I'm aware of. Any other questions about the study? So I just wanted to spend 2 minutes on concussion, partly because there's Howard Goodkin just had done a survey with neurologists and a child neurologist and found that a lot of people still weren't aware of some of the concussion management tools that are out there. So I just want to make sure we don't skip that, though I know Stan Herring, like I said, and Rich Ellenbogen have gone over this. This is one resource that people can can use the CD. You can just type in Google Heads Up Concussion and CDC. They've got a whole bunch of handouts for patients, for providers, for coaches regarding concussion and TBI in sports. So it's a good website. It's also something that's in the news everywhere. That I think there's, if anybody watches hockey, there's a Penguins star player, I guess, that's been out with concussion all season. Each Sunday on in the NFL, there's always somebody who's out with concussion these days, which is a stark change from even 5 years ago. So here is the busy slide about concussion and definitions of concussion. This is from the Zurich Consensus Statement on Concussion in Sports. So this is really more focused on sports, and actually was never published in a neurology type journal. It's been mainly in sports medicine journals, despite the fact that the neurologists have been identified as a specialist who should be evaluating these folks, which is sort of interesting. So basically, concussion, you have a head injury, you hit your head, or there's some sort of rotational force like whiplash in causing an impulsive force, where you have the rapid onset of a short-lived impairment of neurologic function. And that, again, there's mainly a neuropathological change, but not a structural change. And symptoms may involve loss of consciousness or not. I think that's a big thing that people are recognizing now, that you can have a concussion without loss of consciousness. Probably 5 years ago, a lot of people thought you had to pass out to have a concussion. And most of them resolve, but a small percentage of cases have prolonged symptoms. And for sports, as a concussion, they define it as no abnormality on imaging. And this is just a nice picture of some of the forces that are involved, and from the Denver Post. And a brief review of neuropath of concussion. Somebody asked those questions, but that there's a lot of functional changes that may result and end up resulting in alterations, chronic alterations in neurotransmission, axonal deconnection. There's a lot of advanced imaging studies that are going on that sometimes have conflicting results. A little bit challenging to interpret. Here's the compensatory picture of the neuron and neurology grand rounds. I'm not going to go through this. I put the references on here if anybody wants to take a look at the pathophysiology here. But it's sorry, yes, you're right. Proposed. And this is all, when I look at this, because I'm, as Bruce said, I'm not in the lab anymore. I do not play with neurons. I play with numbers and databases and seeing kids in clinic. And so some of this seems to me like it might be a little bit of a stretch. I don't know if anybody was going to crucify me for saying that, because some of this is based on really more like moderate severe TBI models and animals and things. So
your only risk is not saying. Your only risk is to not say.
Oh, not saying. So,
this is conjecture.
Right. So there's a lot that's not, I mean, they're coming up with some pig models that may be more similar to humans, but the mouse models are kind of, for concussion, are a little not quite really, may not be as accurate a representation of human concussion. So this is all proposed, and as far as like the pathophysiology of migraine and how it might relate to concussion, that's all complete conjecture. Magnesium may be involved. I'm not gonna go there at the moment. So this is just the big highlight of the big article that talked about return to play guidelines and concussion in sport, and the SCAT-2, which is a sports concussion assessment tool 2. It says, so again, just briefly, you want nobody at this point, actually there's just a recommendation come out today that no one should return to play after suspected or confirmed concussion the same day, which is actually a change. But in general, you want to start off with light exercise once you're asymptomatic, increase it slightly going on to sort of running drills, and then do it at least 24 hours at each step. Then some non-contact training drills like running sprints, passing, if you're playing soccer, those kinds of things. And then go to a full contact practice after they've been medically cleared and not having more symptoms when they're at the prior step. And then if they're still asymptomatic, can return to playing a game. Of course, kids lie all the time. And there's also impact testing, and kids will fudge their impact testing, which is neuropsych testing done before the season starts, and kids are fudging that so they have a lower baseline score so that they can go back in. But this is in theory if you can get somebody to tell you what's going on. All right, so post-traumatic headaches. Yeah, oh, we got time, 15 minutes. Okay, so how should we manage the kids who do have acute headaches after the concussion? They're right now they're being taken out of school for complete cognitive and physical rest. What do we do? Most of these kids will get better in a day or two or by a week, but there's this group that doesn't get better, and they're still having problems with confusion. Their thinking is slow. They've got bad headaches. They're dizzy. And again, even in the short period, is there something we should do to treat their headaches when they're severe in that day or two after their concussion? And what do we do about the kids who do have prolonged symptoms? And who are they? And is there anything we can do to prevent them? That we don't. So these are a couple of cases, kids I've actually seen in clinic. So this is a 14-year-old girl, never had a headache before, like never was taking ibuprofen. She was actually at a tournament and was asked to kind of do some things for photo op. They had a tennis ball shooting thing, except it shot soccer balls. It was supposed to be for the goalie. They said, "Oh, can you head this, please? And we can take cool pictures." And the husband had it set like at the high setting. Anyway, so she headed 10 balls like a trooper trying to do what she was asked, and then started crying because it hurt her head so much. But she was all good to go back to the games later that day. Unfortunately, she was kicked in the head and had immediate pain, dizziness, nausea, vomiting. She was seen in the ED, was cleared, and by 10 days later she'd gotten better. Then they were on vacation in Hawaii and playing on the beach with her sister, and she bonked heads with her sister. It kind of got a little headache, was kind of quiet in the car later. The next day they're getting in the car, and her sister elbowed her in the head. They really seemed to get along normally okay, I guess, but it was supposedly an accident, triggering a severe headache and dizziness again that made her sent her back to the ER, and where she got IV fluids and treatment. So what to do with her when she shows up in your clinic? The other one is a 16-year-old football player who's a lineman. 2 years earlier, he'd had his first concussion. He took him a couple weeks to recover and was back to baseline. After the injury that I saw him for was he had a helmet-to-helmet collision with a little short headache. Didn't tell anybody. Went back to the game. Hit again. He was horse-collared, which means they grabbed the back of his pads and kind of pulled him down to the ground. Kind of a whiplash injury as well as hitting the back of his head. An immediate headache, felt horrible, and stopped play. I think he was also seen in the ED. I saw him 3 months later. He was still having a headache 4 or 5 days a week. He was out of school. He'd been told to do the cognitive rest till he was back, till he was asymptomatic. So he was, however, playing video games and watching TV. His headache got worse when he tried to do anything. He was going to bed at like 3 a.m., waking up at noon. And he had some balance problems even on exam. And interestingly, his mom had headaches after she was in a motor vehicle accident, but denied migraines. And here's another case of a kid who had a severe TBI. He's hit by a car on the way to school. Bad injury, limb fractures, intubated intracranial hemorrhage at Harborview for 2 weeks, and was in rehab at Children's for 6 weeks. And again, this is one of those kids that didn't, I think probably his headaches were probably related to his trauma, but didn't develop until he was actually discharged from rehab, and then ended up coming back to the ER with bad headaches. He also had lots of other problems that go along with TBI. Problems with sleep, cognitive changes. He also developed tics. He had severe photophobia, was wearing sunglasses, and his limb fractures required surgery and poor balance. And his mom and brother have migraines too. All right, so what do we do for these kids? So you guys all know this stuff, sort of what do you do in a neuro visit. I think for the concussion kids or the kids with TBI, a couple of important things are to find out what their headaches were like beforehand. And everybody will always say, well, they were nothing like they are now. But you have to go back, like, all right, so how often were you taking Advil? And there's kids who take Advil once or twice a week and think that's normal. And you have to tell them that, no, especially in families where migraine runs in the family, that's what everybody's doing. And you have to tell them, no, there are people who actually don't have headaches, and that may not be normal, and that probably puts them at higher risk for having problems afterwards or developing post-traumatic migraine. Find out about what the injury, what has been happening since the injury. Again, the family history, social history is a big deal. And I think sometimes we forget about this part because, like, if this is a kid who is depending on scholarships for football, that's going to be a lot different than a kid who is playing soccer for fun on weekends and has other goals. Other tools you can use, I'll go over, I have some of these if you want. The SCAT-2, and the post-concussive symptom scale are just forms that are actually used on the sidelines. But if you are interested, they do provide a structured interview and kind of a mini mental status that you can just check boxes off on and then compare it from visit to visit, which is what they do in the sports concussion clinic or program. Be sure you examine them, general exam, including their neck, shoulders, face and skull for any tenderness. They have a lot of muscular tenderness or anything else that could be affecting their headaches. And a neuro exam, which you all know, look at their memory, particularly their coordination. Tandem stance is kind of a new thing I learned from the sports concussion clinic, where you actually have them put their non-dominant foot right in front of their dominant foot, like they're doing tandem gait. Have them put their hands on their hips and get steady, and then close their eyes. And it's actually hard to do. If you guys want to do this at home tonight, probably people over 50 will have a really hard time doing it. People under 50, you can still sidestep once or twice in 20 seconds and still have it be normal. So but a lot of the athletes are going to, if it's a really high-level athlete, their balance is usually pretty good beforehand. So if they're really wavering and sidestepping quite a bit and can't do it at all, that's indication that there's still problems with their function. So imaging, again, this is stuff that we go over all the time. This is indications for imaging from the AAP clinical report: severe new headache, focal neuro findings, lots of emesis, altered mental status. The CT if you're looking at hemorrhage or fracture, MRI if you're suspicious for stroke or vascular dissection or other lesion. I think it's important to not put everything up to concussion. That's the other flip side of this pendulum, in that I think in some cases the pendulum is swung a little bit too far in the other direction, sort of attributing everything to concussion. I saw a case on Friday, actually, where I'm like, no, it wasn't really a concussion, and let's see what else is going on. There's a case of a 7-year-old, a football player who had headaches and got his MRI, and he's got a vertebral dissection and lots of strokes, and that's the cause of his headache. So you need to not blame everything on concussion or presumed head injury. Also, look, second impact syndrome is extremely rare. You might be seeing that in the ED, but certainly not in your clinic. That's something that's going to happen within hours of the first impact, unless they've got some other underlying disorder. But also, just looking at other things that cause headaches, making sure there's no evidence of thyroid disease, eating disorder. The gymnasts, and it's just more common in the teenage girls. Depression is going to make things worse. Inflammatory disease, they have lupus or something else going on too. And then drugs and alcohol are also an issue.
I've actually seen lately, I've seen a couple of kids who have POTS and have headaches that are orthostatic, and in the setting of traumatic brain injury,
Yep.
actually as an inciting factor.
Yep. That's what I discovered as I started seeing more kids with headache. There's a pretty significant proportion of them some of them you need to look for this orthostatic changes, and you see it after viral illnesses. I can see it after traumatic or concussion usually, or moderate severe TBI. So that's something else to consider, especially if they're complaining of dizziness, is just taking the time and either doing it yourself or asking the MA to do it or the nurse to do it while you're talking to them, having them do the orthostatic pulse and blood pressure and making sure it's done correctly. So what do we do with acute headaches? Just, again, make sure we're not missing any emergency, and the neurosurgeons talked about this, Ellen Bogan talked about this. No hemorrhage. Again, we talked about the reasons for imaging. No NSAIDs officially until you're sure that there's no bleed, though you don't need a scan to do that, so Tylenol at first. Once you're sure there's no bleed, again, I think that initially rest is a very good idea, that even staying out of school for a day or two if you're having severe headaches after concussion. Cold packs, some heat to the neck. There's some case reports of using triptans for migrainous headaches in teenagers with post-traumatic headaches or headaches after concussion. No studies. There are about 3 or 4 case reports, and people see some of these kids have tried them with anecdotal success. Avoid things that make them worse. Stay well hydrated, and this is sort of going down. They're a week, 3 or 4 days out. Some people will use sort of routine NSAIDs, and again, possibly the triptans for an acute headache. Again, stay well hydrated, unstressed, try to rest. And most of these kids, 90% of them will be getting better as long as they don't get another head injury in 1 to 2 weeks. So, what do we do for the kids who don't? And is there any data? No. So basically, you try and manage, like migraine, manage the headache based on the kid's other symptoms. I think the big thing here is going to be subthreshold exercise. So that once, and I sent out a survey to some folks in the American Headache Society and the Pediatric Special Interest Group, seeing what they do with these kids with concussion and headache, and how long they wait to get them back to exercise, and it varies widely. But there's certainly evidence that subthreshold exercise, when some headaches become more chronic after a couple of weeks, is not harmful and may be beneficial. And I think like sitting on the couch playing video games for 3 months after a concussion is going to make everything worse, not better. So they need to get back to exercise, but you need to couch that in terms that they don't think they can go do wind sprints on the first day that they're back. So, and it needs to gradually improve, because these kids will feel better for a day and then they'll go like work out for 4 hours and be back puking in your office or in the ER, which is no fun for anybody. Physical therapy, massage therapy, no data, but if there's a lot of neck tension or shoulder pain, think about that. I think the supplements are not harmful. And there's some thought that the omega-3 fatty acids may be helpful, magnesium may be helpful, B2 is helpful for migraine, CoQ10 may be helpful for migraine, and they're not super expensive, and they probably won't cause harm. Then we'll talk about medications in a minute. Counseling, I think, can be a big factor, especially if it's a kid who's being retired from play or is out of play when they don't want to be, and especially if they're counting on it for their future, or if they were the quarterback and sort of the popular guy in school, and now he's not. And that was sort of his identity, or her identity was as an athlete, and now they're not. Acupuncture and biofeedback are other treatment modalities to try. Autonomic symptoms are common, like you're saying. Big thing, I think, is to avoid making things worse. So try to avoid medication overuse. I don't think they should be taking NSAIDs. They can try that for maybe first 1 or 2 weeks, but after that, it's probably not helping and may be hurting. And certainly opiates. Even when I surveyed the folks from the American Headache Society list, a couple of them were talking about using opiates, which I think is not a good idea, because it changes the physiology and can make pain worse in the long term, and actually change and lower your pain threshold. That's a whole other talk. So just the general stuff: sleep, meals, activity, and managed appropriately, doing some exercise but not a lot, relaxation, rest, or finding sort of biofeedback, meditation if that helps, and avoid your triggers. That's basic stuff. These are medications that are used. None of them have been studied in the treatment of post-traumatic headache. There's case studies, that's about it. And avoid medication overuse. These are, again, preventative medications that are being used. Absolutely no studies on these in post-traumatic headaches in kids, or very little data in adults. The biggest ones that are most commonly used are amitriptyline and Topamax. So everybody with Topamax, I have concerns that if kids got cognitive issues after concussion, that's going to, or TBI, that's just going to exacerbate things. Same concerns for amitriptyline. But if I have a kid who's got chronic, like we'll see in a minute, the football player's got chronic headaches, isn't sleeping, you can try one of the amitriptyline or nortriptyline or one of the TCAs. And again, magnesium and the omega-3 fatty acids, I think, are unlikely to hurt as long as the kid's otherwise healthy, doesn't have kidney disease. But zero data, and there's people who feel very strongly about this without data on either side of the issue. So headaches are common. Acute headaches are common after TBI. Make sure you're not missing anything life-threatening or serious or progressive. Manage with rest, hydration, and some NSAIDs initially. Severe headaches, I think maybe if you see a kid in the ED, I don't usually see them at that point. It might be, and they have a migrainous headache, or especially if they have a headache history of migraine or a family history of migraine, trying a triptan may be reasonable. Think about the return to play guidelines, and most of the kids' headaches will get better. The chronic headaches, and again, this is interesting in that, again, somebody commented, well, I would love to be able to treat those because they just go away on their own. Great thing to see in clinic, right? But the same meeting, somebody else commented that they had this common disorder that was seen in 1 in 25,000 kids. So that's sort of the interesting part about headache. Okay, so we're almost done. So we started a minute late, so I'm giving myself 1 minute leeway. So chronic headaches are, again, subthreshold exercise, and I think is going to be a mainstay of therapy, considering the supplements and prescription medications if appropriate. So what happened to our kids? So she's, again, seen in the ER. She stopped playing soccer. She got better after about 3 weeks. She went to gymnastics a couple months later. She was fine, and then she developed a migraine headache without any obvious head trauma. Was bad enough she was seen in the ER, but then no problems after that. So what's wrong with
Stayed
her?
away from her sister.
Yes, stayed away from her sister, hopefully. She had a maternal aunt with a migraine, but no one else in the family. So is this migraine trigger or trauma-triggered migraine? That's what some people will talk about. Should she go back to playing soccer? Was one of the major questions they had for me in clinic. And as a family, they kind of decided that wouldn't be the best idea for her because she had significant symptoms with her first concussions. But I couldn't say no. If this is going to be your livelihood, you have to retire. I didn't feel right saying that. I said it was probably not a good idea. And advised again, treatment of the migrainous headaches is typical. So the lineman, so he still had lots of problems. We tried amitriptyline. He didn't like it. He was getting depressed. He wasn't exercising. His sleep was terrible. We started trying Topamax, PT, counseling, and pain clinic. And he got school accommodations, and a 504 plan was meant to let it start. So he started walking back and forth to school. So he was walking 2 miles a day, and that is when he got better. And he's still working with Kathy Bell. Actually, he's 18 now here. But his headaches are much better, and he's much more functional. So I think he probably had a predisposition for headaches. Okay. So I have one more slide. Okay. So again, our kiddo with severe TBI, headaches improved in a couple. He started some propranolol, actually. Amitriptyline is going to make his tics worse, and that seemed to help his headaches. And he did not have a lot of autonomic issues, actually, but the propranolol did seem to help for him. And a year later, he was not having any problems with headaches, and we took him off the propranolol about 6 months into it, and has occasional mild headaches. His photophobia has improved, and his mom and brother still have migraine. So thanks for coming, and apologize for staying a little bit over. Any?
Can we open up the questions?
Oh, sorry. That's right. Thanks. Okay. Okay. Did I control? Sorry. I guess there's some way. So to control for other factors in the model. Yes, we did control for the other factors in the model that we looked at. So we did. So did we control for other factors in the model, whether related to headaches? We did control for SES, race, parent education, and insurance status. And Tom McFarland is, but we're not sure. He's over 50. So, yes. So if you can do it, great. But don't be sorry. Don't be too worried if you fall over. Was the point? And are there more questions? How do I figure that out?
How do you decide who to send home and who to admit overnight in the emergency room? Somebody's bumped his or her head, maybe been briefly unconscious, throwing up.
Well, I think you want to make sure that they're stable. So if they're continuing to throw up, I think probably people are going to scan those kids if they're altered and still vomiting, and if they have a CT. And it depends on the family situation, I think. That if they're continuing to vomit and still altered, you're probably going to admit those kids and observe them overnight just to make sure that there's nothing that was missed and that they do recover. If they've got a bad headache and they've stopped vomiting and they're answering questions and acting appropriately, then I think, and they've got good supervision at home, I think you can send those kids home.
You CT everybody?
No.
No.
No, there's some. I didn't go over them in detail, but there are some guidelines for. I can pull them up again if you want. Guidelines for who should get scanned. So if you've had new onset severe headache, which is that's I think one of the reasons that a lot of kids get scanned. Certainly, if there's focal neurological findings or repeated emesis, or if they're not back to their baseline. And so I think a lot of kids are getting scanned, and you can do a whole talk on the imaging after concussion and indications for imaging and controversies there, and when you don't need to. There's some algorithms that are out there for when you need to image after head trauma, and we're probably imaging too much still, but because most kids don't.
Thank you very much. And thank you also on behalf of Bruce and the
Yeah.
So I think that what we can do is, if there are no further questions, we can convene in 5 minutes. Our next speaker is already here.
Thanks.
Thank you so much.